Hello and welcome. I am Dr. Anil Joshi, Professor of Radiology. Welcome you to this series of Learn Radiology Basics from the Professor. Today's topic is Distal Cologram. Today's topic has got a special feature that it has got an embryological basis and it is in continuation of invertogram which we are seeing in other lecture series. In today's series we will be seeing only distal cologram and that also the radiological application along with the embryological basis of it. Now let's get started. Introduction. It is a most frequent congenital anomaly, that is ARM, found in pediatric surgery. The ARM, ANO-RECTAL malformation, for which distal cologram is performed, is one of the most frequent abnormality. ANO-RECTAL malformations are seen in approximately 1 in 5,000 live births. 20 to 70% of the patient has other congenital anomalies of spine or any other structures. There is a male predominance. Spine, genitourinary, gastrointestinal, cardiac system are frequently affected. This we have seen as a vector anomaly in some other lecture also in full details. ANO-RECTAL malformations are abnormalities in formation of cloaca and or ANO-RECTAL septum. The detailed embryological basic of this we are going to see in subsequent slides. If the cloaca is too small, or uro-rectal septum does not extend far enough caudally, these are the two conditions, then the opening of the hindgut shifts anteriorly, leading to a opening into urethra or in vagina. Again, the clinical application of this we are going to see in subsequent slides. Now, how the clinically these newborns presents. Initially, it is suspected when a clinician do not see a anus. Either he sees it some other region, that is ectopic, or there is no anal opening in normal position. So this is the first clinical indication for clinician to suspect ANO-RECTAL malformation, anal opening at wrong place, and second, absent anal opening. These are the two clinical indications to suspect ANO-RECTAL malformation. Then what happens? There is a dilated proximal rectum. Now we have seen in invertogram how it looks like. From this dilated rectum, there can be a fistulous tract. So there can be a connection or fistulous opening in intestine or in urinary bladder. Now a connection joining the intestine and vagina needs to be demonstrated. In female, the intestine can get joined with the urinary system and vagina in a single opening known as a cloaca. Now, after knowing this clinical background, what are the objective of this study? Now, the objective of this study is to confirm level of blind ending pouch. Whatever blind ending pouch we have seen on invertogram, reconfirm or more investigate in detail in this distal cologram. Second is to confirm presence and level of fistula between the gastrointestinal and genitourinary system, and to see for associated bony abnormalities if present, particularly of the skeleton. Now let us come to a embryological basis. Embryology plays essential role in evaluation of these patients because the fistulous tract or the anomalies can be explained best on the basis of embryology. Now let us go into detail of this embryology. The hindgut gives rise to a distal third of the transverse colon. The descending colon, the sigmoid and the rectum and the upper portion of the anal canal is in formation stage. The hindgut enters the posterior portion of the cloaca to form a future ANO-RECTAL canal. The allantois enters the anterior portion of the future urogenital sinus. The urogenital septum is formed by merging of the mesoderm covering the allantois and the yolk sac. Explanation is better seen in the diagram along with the illustrations. Now, a caudal folding of the embryo continues. The ANO-RECTAL septum moves closer to the cloacal membrane. Breaking down of the cloacal membrane creates an opening for the hindgut and one for the urogenital sinus. The tip of the ANO-RECTAL septum forms the perineal body. Now we are seeing up to the formation of perineal body. Now classification is important. There are multiple classifications. Now whichever classification we follow is okay. I am giving you all the classification they are present. So wing spread classification, then Penrose classification, Krakenberg classification, and anatomical classification. So whichever classification we follow is okay. Now here we comes to a term high, intermediate and low type. These are also described in a lecture when we have covered a invertogram, or that is ANO-RECTAL malformations, clinical presentation and radiological diagnosis as a newborn, as an initial investigation. Now this can be a high type, this can be a intermediate type, or it can be a low type. Now what is the meaning of high type? In male it is ANO-RECTAL agenesis, then with retroprostatic urethral fistula. Now anal agenesis can be associated or may not be associated with rectoprostatic urethral fistula. So with and without both are covered in high type of classification, and there can be a rectal atresia of the distal segment or of the more larger segment. Now in female, ANO-RECTAL agenesis with rectovaginal fistula, without fistula, and with rectal atresia. So more or less, except for certain things, the basic remains the same. Now what is the intermediate type? It is rectobulbar urethral fistula. So there will be rectobulbar urethral fistula, and there can be anal agenesis without fistula. So with fistula, without fistula. What happens in female is rectovestibular fistula and rectovaginal fistula, and third is anal agenesis without fistula. Now third is low type. What happens in low type? These anocutaneous fistulas are there, or there can be anal stenosis. Anal is there, anus is there, but it is just a stenotic. Now what happens in female is ano-vestibular fistula, anocutaneous fistula, or anal stenosis. Now rarely a cloaca can be repellent. So these are the classifications which are commonly referred. Now this classification is a bit in more detail. So we are holding this slide for 20 seconds. You can go through it and learn it. Now, anatomy is the anatomical classification. Now, anatomical classification is comparatively easy. What it says is, in male there can be a perineal fistula. In male there can be a perineal fistula. Then there can be recto-urethral fistula. So rectum, it can go into the urethra, either in bulbar urethra or in prostatic urethra. This illustration we are going to see when we will be seeing actually the films and the results of this study. Then there can be rectovesical fistula, from rectum directly into the bladder. So there can be imperforated anus without fistula. So just imperforated anus and blind ending rectum. Or there can be rectal atresia with different lengths. In female it can be perineal fistulas, vestibular fistulas, then persistent cloaca. There are different measurements, less than centimeter, more than centimeter. Then imperforated anus without fistulas and rectal atresia. These are the different classifications. Now what are the subtypes? Subtypes are better explained with the help of these diagrams. Now subtypes of recto-perineal fistulas. So these are we are going to see in detail by the help of these diagrams. Then it is a low ARN. Variety of ARN, it is low variety. Rectum is with most of the sphincter mechanism. So rectum is with sphincter mechanism. Then lowest part is anteriorly mislocated. Then anal fistula's opening is stenotic or follows a subepithelial midline tract opening along the midline, that is perineal raphe, scrotum, or even at the base of the penis. So opening can be, as it is seen here, it can be at different places in male, at the base of the penis, or it can be base of the scrotum, or at raphe there can be an opening of it. In female, the cleft is equivalent to that of males. The rectum and vagina are well separated in this condition. Now, types of recto-urethral fistulas. This we are going to again have more illustrations when we are going to see our study results. The imperforated anus with a recto-urethral fistula is the most common defect in male. The fistula may be located at the lower bulbar or higher prostatic portion of the urethra. Then immediately above the fistula, the rectum and the urethra share a common wall. The lower the fistula, the longer is the common wall. This is an important anatomic fact which guides the operator, that is the surgeons and radiologists, to diagnose. Lower urethral fistulas are commonly associated with good quality muscle mechanism, that is retained sphincter activity and well developed sacrum, a prominent midline groove and a prominent anal dimple. So these are the features. Now, higher urethral fistulas are frequently associated with poor quality muscle, that is poor control over the further functions, and abnormally and poor midline groove and a barely visible anal dimple. So in these patients, a anal dimple will not be visible. Now, what are the types of ARN, that is rectovestibular fistulas? A rectovestibular fistula is the most common defect in the females and has an excellent functional prognosis. The diagnosis is based on clinical examination. The meticulous inspection of the newborn genitalia allows the clinician to observe a normal urethral meatus and a normal vagina with a third hole in the vestibule, which is the rectovestibular fistula. About 5% of these patients will have hanging vaginas and a septum. Now, subtypes of ARN, that is the recto-bladder neck fistulas, that is the rectum to bladder fistulas. In this defect, the rectum opens into the bladder neck. The patient has usually poor prognosis of the bowel control because of the levator muscles. The striated muscle complex and the external sphincters are commonly developed. The sacrum is often formed and it is a short. Sacrum is deformed and it is short. In fact, the entire pelvis seems to be underdeveloped. So because of underdevelopment, the sacrum is also, it looks a deformed and a small. In perineum is often flat, which is evidence of poor muscle development, and about 10% of the male into this category. Now, subtypes of ARN, that is the imperforate anus without fistula. So ARN can be without fistulas. The rectum usually terminates approximately 2 centimeters from the perineal skin. The rectum and the urethra do not communicate. These two structures are separately only by a thin common wall. So there is a thin common wall which separates a rectum and urethra. About half the patients with no fistulas also have Down syndrome. So commonly associated with Down syndrome at 50% of the patients, and more than 90% of patients with Down syndrome and imperforate anus have this specific defect, suggesting chromosomal link. Now, this is another subtypes of ARN, that is rectal atresia. In this, the lumen of the rectum is totally atretic or partially stenotic. So there can be stenosis or atresia. The upper pouch is represented by a dilated rectum, whereas the lower portion empties into the small anus, that is small anal canal, and is the normal location and is 1 to 2 centimeter in length. These two rectal structures may be separated by a thin membrane or by a dense fibrous tissues. The repair involves a primary anastomosis between the upper pouch and the lower anal canal and is ideally approached posterior sagittally with splitting of the anal canal longitudinally. Further subtype of ARN, persistent cloaca. The cloaca is persistent in this patient. A cloaca is a defect in which the distal portion of the rectum, vagina and the urinary tract fuses and create a single common perineal channel. A careful separation of the labia discloses a single perineal orifice. The length of the common channel varies from 1 to 2 centimeter and is very important for the operative and prognostic complications. Now, subtype of further ARN, that is the persistent cloaca. In this condition, a common channel of less than 3 centimeter usually means that the defect can be repaired with posterior sagittal operation without opening the abdomen. A common channel longer than 3 centimeter are more complex. Mobilization of the vagina is often difficult and some forms of the replacement may be needed for vagina during the definitive repair. Now, this is further, that is the further subtype of ARN, persistent cloaca, frequently is abnormal distorted, full of secretions. So these are different types of cloacal abnormalities what we are seeing. The distended vagina compresses the trigone and transfers with drainage of the ureter. The distended vagina compresses the trigone and interferes with the drainage of the ureter. So the ureter do not empty properly and is frequently associated with hydronephrosis due to obstructive lesion. This condition may be diagnosed prenatally. The dilated vagina can also become infected, that is pyocolpus, and may lead to perforation and peritonitis. Such a large vagina may represent a technical advantage for the repair as there is more tissues for facilitated reconstructions. Now this is another variety in which you are seeing further malformations and abnormalities. Now these things are diagnosed initially by two things. One thing is the invertogram, which we have covered on some different topics, and second is the prone table lateral, which many people feel they are more comfortable with this technique. In this, it is a prone cross table lateral position taken for the imperforated anus to know whether the abnormality is high type or low type. The baby should be placed in the genopectoral position for 3 minutes before taking the film to allow gas to displace meconium and rise to the termination of the pouch. So terminal pouch has to be seen, and that gives us the idea whether it is high type, low type or intermediate type. The barium paste or the contrast soap gauze placed in the natal cleft is more accurate than metal marker. This is a technical reason. A catheter may be placed in the urethra to mark delineation of the urethra, more obvious, although this is not essential. The greater trochanter should mark with marker paint and the upper thigh and the X-rays being centered on this spot. Now more details of all these procedures, particularly the invertogram, is covered in some other lecture series. In that we have advantages of invertogram over the cross table lateral. However, this technique is comfortable for the patients, that is the babies, and therefore at many centers it is adapted, and invertogram is technically difficult. So you need to have a very good quality technician and a good teamwork to get the invertogram. Now here what we have discussed in detail are diagrammatically shown here. So what you are seeing is the fistulous tract. So from rectum it is opening into the raphe, or it is in base of the penis. Now second is the blind ending fistulous tract opening into the urethra. Third, it is prostatic urethra, and fourth, it is in bladder. So this is in short what we are going to see at every film. What we are going to read is going to be a landmark. Now see here, this is a distal cologram. Now how a distal cologram is performed? Distal cologram is performed by two methods. One thing is you can have a self-retaining catheter. The Foley's catheter, which is self-retaining, is put into the colostomy opening. So colostomy opening identified, a Foley's catheter is put. You can inflate the balloon, and once you know it is adequately fixed, you start putting barium. Now barium needs to be observed under fluoroscopy, so there should not be any over-distension. What can happen to this barium? One thing is there may not be any fistulous opening, it can remain just in the terminal rectum. Second thing, there can be a fistulous tract at different organs, which are usually bladder, this can be urethra, prostatic urethra, or it is in the perineum. It can open as the different fistulous tract opening. Now in this tract what we are saying is You have to analyze with the help of figure that the distal cologram where the barium is filled through the colostomy and that has entered into the bladder. So now if the urethral opening is there or fistulous tract opens into urethra, there is no reason why bladder should be filled. So the moment we see a bladder filling, there has to be opening either at bladder or at the bladder neck. Then only the barium can regurgitate or go into the bladder. So this is the important when you see a bladder and when you don't see a bladder. Now here what we are seeing is exactly same, but here the urethra is showing some abnormality. There is a stricture urethra, there is a bladder which is behind the distended rectum. This is a lateral projection. Here also you have to see that all the sacral segments are present. So presence of sacral segment is essential in addition to the diagnosis of fistulous tract. Now here bladder is not distending. That means the fistulous tract is opening after the external sphincter. That is what you are seeing here. But some dye is going into the urethra and then outside. Fistulous tract is marked as a narrow column. So there is a rectum first. From rectum you can see the inflated Foley's balloon, and below there is a prostatic urethra in which the dye has gone beyond and into the urethra it is coming out. So you can classify it as per the reference diagram. Now here again it is going into the bladder. So bladder is getting distended, urethra is opacified. This covered film, as I described, is extremely important to know 3-4 things. One thing is to know colostomy side, whether it's right sided or left sided. The second is sometimes we put a rigid catheter to know the inside anatomy. So it is one of a routine technique that a catheter is put before along with the scout film. So scout film is essential for these 2-3 point of view. Now here what we are seeing, it is a right-sided colostomy. From right-sided colostomy a dye is put. There is no fistulous opening. And what is happened to the colon? Colon is microcolon. So this is the additional information what we have got is there is entire large bowel is involved. It is not distending. There is a microcolon. In addition, it is a case of imperforated anus and there are no fistulous tract opening into the bladder or into the urethra. Now here again it is blind ending. So not necessarily all the time the barium should go from the blind ending to the fistulous tract. Sometimes there may not be any fistulous tract. So what is seen in this case? There is no fistulous tract. It is just a distended rectum what we are seeing, and there is no passage going into the bladder, urethra or anywhere externally as an additional opening. So this blind ending rectal pouch and no fistulous communications. This gives us some more information than just a blind ending tract. The tract is blind ending, that is correct. But if you see very carefully the direction is going not to the midline, but it is going towards right side. Now again if we see in the upper films, okay, the stomach is not seen, but the liver is seen. The liver is on left side. Left side liver, again you have to make a mention of it that it's one of the additional abnormalities. So in this patient you may have a rotation of gut in addition to the ANO-RECTAL malformation. Now here what we are saying is there is a rectum over distended with the barium, then there is a bladder. Now look at the shape of the bladder. Shape of the bladder is slightly distorted. Now here it is the same patient what we have seen earlier, and additionally what we are seeing urethral and bladder opacification. Now is it that bladder is going into the midline? No, it is eccentric. So some bladder abnormalities need to be investigated following this procedure. Now here the left-sided colostomy, the dye is going towards the right side, and from right side it is coming down. There is no fistulous tract. So it is redundancy of large bowel. The large bowel is redundant and there is no fistulous tract. Additional finding was redundant large bowel. It is practically crossing midline and going almost into the right iliac fossa. Now here what we are seeing is the over distended stomach, over distended bladder. From bladder dye is going into the rectum and also into the fistulous tract. So here what we have to note are the dye is going into the barium is going into the large bowel also, then it is going into the bladder also and in urethra also. We have seen a lot of films. In last film I have not given the diagnosis. You are supposed to read it. You are supposed to correlate it with the reference diagram, and you are supposed to write your own report with the help of all these things. I have shown you multiple films. Before that, I had told you what is the imperforate anus, how it is diagnosed is by the invertogram. That can be either invertogram or it can be a cross-table lateral film, shoot-through film, which can give us the idea that there is a high type, low type or intermediate type of anal or ANO-RECTAL malformation. Now once we come to the conclusion, then usually the patient is followed with a colostomy. After colostomy, patient comes for the distal cologram. It is very important to know what is the importance of distal cologram. Distal cologram gives us an idea about fistulous tract, whether the present or absent. If fistulous tract is present, first what we have to treat is the fistulous tract before going for the reparative surgeries. So it is extremely important from surgery point of view for radiologists to tell whether there is any fistulous communication, whether there is abnormal communications, or what is the type of abnormality it is. A plain invertogram, a plain cross-table lateral can give fairly good idea, but ultimately this procedure gives you good idea or better idea as far as anomalies are concerned before they go for the reparative surgeries. So it is extremely important to perform this procedure in a proper way and to demonstrate a fistula. Here we conclude that distal loopogram, what sometimes it is called, or distal loop cholangiogram or distal cologram, is useful study to confirm level of blind bowel pouch. It is just a blind ending, it has got fistulous tract or it has got some other abnormality, has to be seen. Then not only it gives us idea about presence of fistula or not, but it can give us a fairly good idea about the gastrointestinal and genitourinary system. With this, we come to the end of this short topic. Though it is a short, it's a very important, because error in this test can lead to major problems. So therefore, it has to be done properly and it has to be read and interpreted properly. With this, I am Dr. Anil Joshi. Thank you for giving me your valuable time. Please note, radiology is not a race, it's a process. Be a part of this process and enjoy the feast of knowledge. Not only because of your proper techniques, you will be benefited, but the patients, babies will be benefited, and therefore it is extremely important that you should do these procedures very accurately. You should not leave any technical errors. And with this, again I am Dr. Anil Joshi telling you that I am logging off, but promising you to meet again with the next lecture.